Welcome to our video on prothrombotic disorders. Let's begin. In this lecture, we will discuss the prothrombotic disorders. These include antiphospholipid syndrome, factor V Lenden, protein C and S deficiency, antithrombin III deficiency, malignancy, and pregnancy. Let's start with antiphospholipid syndrome. Antiphospholipid syndrome is an autoimmune hypercoagulable disorder. It can be primary or secondary to the other autoimmune disorders such as systemic lupus erythematosus. As the name implies, antiphospholipid antibodies damage the phospholipids on the endothelial cells, predisposing to arterial and venous thrombosis. Antiphospholipid syndrome is characterized by both venous and arterial thrombosis. Therefore, these patients can present with deep venous thrombosis and pulmonary embolism. They might also have myocardial infarction, acute limb ischemia, stroke, or transient ischemic attack. Additionally, it's very high yield to know that patients with antiphospholipid syndrome may also present with pregnancy complications. They might have 3 or more unexplained fetal loss before 10th week of gestation, or 1 or more fetal loss after the 10th week of gestation. The patients may also present with at least 1 premature birth of a normal neonate due to preeclampsia, eclampsia, or placental insufficiency. Now we will discuss how antiphospholipid syndrome is diagnosed. The patient must meet at least 1 clinical criterion that we discussed on the previous slide and at least 1 laboratory criterion that you will see on this slide. Laboratory criteria include the antibodies specific for antiphospholipid syndrome. One of these antibodies is anticardiolipin antibody. Clinical significance of this antibody is that it yields the false positive venereal disease research lab, VDRL, test result. Another antibody is lupus anticoagulant. Lupus anticoagulant falsely prolongs the PTT. This is because lupus anticoagulant inhibits the reagents used for measurement of PTT. However, please keep in mind that antiphospholipid syndrome is hypercoagulable rather than hypocoagulable disorder despite prolonged PTT. The third antibody is the anti-beta-2 glycoprotein antibody. Since patients with antiphospholipid syndrome are at high risk for arterial and venous thrombosis, we use heparin for acute thrombotic events. These patients also need lifetime anticoagulation with medications like warfarin. Let's try a question. A 30-year-old woman comes to the physician for a preconception visit. She had 3 consecutive abortions before the 10th week of gestation. She also had incidents of deep venous thrombosis at the age of 20. The current VDRL test is positive. FTA-ABS comes back negative. What's the likely explanation for the patient's test results? The patient has had 3 consecutive abortions before the 10th week of gestation. She also has deep venous thrombosis at the age of 20. These clues point towards a diagnosis of antiphospholipid syndrome. Anticardiolipin antibody in the patient with antiphospholipid syndrome yields the false positive VDRL test result. False positivity of the patient's VDRL test result is confirmed by negative fluorescent treponemal antibody absorption. Therefore, we should consider the antiphospholipid syndrome as one of the differential diagnoses of false positive VDRL. Here you see the graphical representation of what factor V Lenden is. Normally, activated protein C, which consists of protein C and S, cleaves the factor V into small degradation products. When the factor V is mutated, activated protein C can no longer cleave it, resulting in accumulation of factor V Lenden. Diagnosis of factor V Lenden is based on positive family history for thrombotic events. Additionally, increased D-dimer and genetic testing for factor V mutation are used to diagnose factor V Lenden. Treatment for factor V Lenden is heparin after acute thrombotic event. These patients should receive long-term treatment with direct oral anticoagulants. Additionally, oral contraceptive pills should be avoided in these patients to prevent thrombotic events. Now we'll talk about protein C and S deficiency. Deficiency of either of these 2 proteins is an autosomal dominant disorder. Protein S is a cofactor for protein C. They combine in order to degrade factor V and factor VIII. Deficiency in any of these proteins will cause impaired degradation of factor V and factor VIII. This in turn will cause sustained activation of coagulation system. There is one very high yield point to know about protein C and S deficiency. These patients have increased risk of thrombotic skin necrosis after warfarin administration. Warfarin normally inhibits synthesis of vitamin K-dependent coagulation factors. These factors are 2, 7, 9, 10 protein C and S. Protein C and S have relatively short half-lives compared to procoagulant factors. Procoagulant factors still present in the blood, and decreased protein C and S in the setting of warfarin administration results in an initial hypercoagulable state. Patients with protein C or S deficiency have an even greater imbalance between procoagulant and anticoagulant proteins during warfarin administration. This will result in thrombotic skin necrosis. Clinical features of protein C and S deficiency include deep venous thrombosis, pulmonary embolism, and recurrent pregnancy loss. Here you see the graphical representation of how protein C or S deficiency cause hypercoagulable state. As we already discussed, activated protein C, which consists of protein C and S, cleaves the factor 5 and factor 8 into the small degradation products. When there is deficiency of either protein C or S, there is increased concentration of factors 5 and 8, leading to thrombosis. This image shows thrombotic skin necrosis after warfarin administration. Please note this dark discoloration of the skin suggesting necrosis. Diagnosis of protein C and S deficiency is based on positive family history for thrombotic events. Additionally, increased D-dimer and genetic testing are often performed. Finally, measurement of protein C and S concentrations in the blood can confirm the diagnosis of protein C and S deficiency. Treatment includes heparin after acute thrombotic event. Long-term treatment involves either warfarin or direct anticoagulant. Choice of long-term therapy depends on multiple factors which are beyond the scope of USMLE Step 2 CK exam. Let's move on to antithrombin III deficiency. Antithrombin III deficiency can be inherited or acquired. Inherited disease is autosomal dominant. Acquired antithrombin III deficiency is commonly caused by nephrotic syndrome due to loss of antithrombin III in the urine. Antithrombin III normally degrades factors 2A, 7A, 9A, 10A, 11A, and 12A. Deficiency of this enzyme will result in decreased degradation of these factors and a hypercoagulable state. It's very high yield to know that antithrombin III deficiency is characterized by insufficient rise in PTT after heparin administration. Let's take a step back and explain this concept. Normally, heparin stimulates antithrombin III to inactivate factor 2A and 10A. If the patient has antithrombin III deficiency, heparin can no longer bind to this enzyme in order to induce sufficient degradation of 2A and 10A. This is why PTT will not rise sufficiently after heparin administration. Clinical features of antithrombin III deficiency include thrombotic conditions like deep venous thrombosis, pulmonary embolism, and renal vein thrombosis, and so on. Here you see the illustration showing how heparin and antithrombin III work. Heparin stimulates antithrombin III in a way that it preferably degrades factors 2A and 10A. Degradation of these factors results in elevation of PTT. If the patient has antithrombin III deficiency, then heparin will no longer be able to sufficiently activate the enzyme. Therefore, PTT will not rise to the expected level. Diagnosis of inherited antithrombin III deficiency is based on positive family history for thrombotic events. Genetic testing can also be done. Finally, measurement of antithrombin III concentrations in the blood can confirm the diagnosis of antithrombin III deficiency. Treatment of acquired antithrombin III deficiency is focused on management of underlying condition. Anticoagulation is also considered an acquired form of this disease. Inherited antithrombin III deficiency is treated with lifetime anticoagulation with warfarin. Let's try a question. A 25-year-old man is brought to the emergency department due to severe right calf pain. The physical exam reveals erythema, swelling, and pain of the right calf. Doppler ultrasound confirms the diagnosis of deep venous thrombosis. This is his third episode of deep venous thrombosis in the past year. He's had an episode of pulmonary embolism at the age of 20. His PTT is 35 seconds. He was given IV heparin, after which his PTT became 37 seconds. What's the most likely explanation for the patient's laboratory findings? This young patient presents with the third episode of DVT in the past year. He had pulmonary embolism at the age of 20. Considering these clues and his age, he likely suffers from an inherited hypercoagulable disorder. IV heparin administration resulted in negligible elevation in PTT. This finding suggests antithrombin III deficiency. Now we will discuss malignancy in the context of hypercoagulability. Tumor cells commonly release the procoagulant substances like mucin, which activate coagulation system leading to thrombosis. Clinical features may include DVT and pulmonary embolism. It's very high yield to be familiar with Trousseau syndrome, also known as superficial migratory thrombophlebitis. Trousseau syndrome is the paraneoplastic syndrome caused by internal malignancies, classically the pancreatic cancer. It is characterized by migratory thrombosis of superficial veins. Patients often develop erythematous, indurated, and painful cords on the skin corresponding to thrombosed and inflamed veins. Here's an image of a patient with Trousseau syndrome. Please note the swollen, erythematous, and indurated cord on the leg, suggestive of thrombophlebitis. Diagnosis of malignancy is typically accomplished by biopsy. The imaging studies such as CT, MRI, or PET may also be helpful in diagnosing the malignancy. The diagnostic approach depends on the specific tumor. Treatment may include chemotherapy, radiotherapy, or surgical excision. Anticoagulation therapy should be administered in a case of acute or recurrent thrombotic events. Let's finish this lecture by discussing pregnancy in the context of hypercoagulability. Increased estrogen during pregnancy induces hepatic synthesis of coagulation factors. Increased amount of coagulation factors, in turn, increases the risk for thrombotic events. Due to these changes, pregnant women may develop DVT or pulmonary embolism. Diagnosis of pregnancy is most often based on urinary beta-HCG and transabdominal or transvaginal ultrasound. Treatment of hypercoagulable state during pregnancy is usually not necessary. However, we should consider heparin for high-risk patients, including those with positive family history for thrombotic events. It's worth mentioning that warfarin should be avoided during pregnancy due to its teratogenic effects. This table summarizes all the prothrombotic disorders that were discussed in the lecture. Please pause the video and take a moment to consider this table. A 21-year-old man is brought to the emergency department due to sudden onset of pain in his left calf. The physical exam reveals erythema and swelling in the left calf. Dorsiflexion of the left foot elicits a dull pain in the calf. The patient's father and paternal grandfather have had multiple episodes of DVT. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 115/70, a heart rate of 82, and a respiratory rate of 15. Anti-cardiolipin and anti-beta-2 glycoprotein antibodies are negative. PTT is normal. He is administered intravenous heparin. After several days, he is discharged with a prescription of warfarin for the next 3 months. 4 days after discharge, the patient is readmitted due to skin necrosis on his right leg. Which of the following is the most likely diagnosis in this patient? A. Factor V Lenden. B. Antiphospholipid syndrome. C. Protein C deficiency. And D. Antithrombin III deficiency. The patient presents with erythema, swelling, and pain in his left calf. Dorsiflexion on the left foot elicits dull pain in the calf. This is the positive Homan sign suggesting a DVT. Considering his young age and positive family history of DVT across multiple generations, this patient likely has an inherited prothrombic disorder. After several days, he is discharged with a prescription of warfarin for the next 3 months. 4 days after discharge, the patient is readmitted due to skin necrosis in the right leg. Warfarin-induced skin necrosis is commonly seen in patients with protein C deficiency. This is because warfarin inhibits hepatic synthesis of factors 2, 7, 9, 10, and protein C and S. Protein C and S have short half-lives compared to factor 2. Therefore, before the warfarin exerts its therapeutic effect, there is imbalance of procoagulant and anticoagulant factors in the blood. Excessive amount of factor 2 along with low levels of protein C and S predispose the patient to small vessel thrombosis in the skin. This is why the patient with protein C deficiency may present with warfarin-induced skin necrosis. So the correct answer is option C. Here's a slide reminding us of the general characteristics of protein C and S deficiency, including warfarin-induced skin necrosis. Let's discuss why the other options are incorrect. Option A, factor V Lenden, is incorrect because although it's the most common inherited prothrombic disorder, it does not present with warfarin-induced skin necrosis. Option B, antiphospholipid syndrome, is incorrect because anticardiolipin and anti-beta-2 glycoprotein antibodies are negative. Additionally, PTT is normal. PTT is often falsely prolonged in patients with antiphospholipid syndrome due to lupus anticoagulant antibody. Finally, option D, antithrombin III deficiency, is incorrect because it is not characterized by warfarin-induced skin necrosis. Instead, antithrombin III deficiency is characterized by negligible or no change in PTT after heparin administration. And that concludes our lecture on prothrombotic disorders.